So first of all, hello everyone. Thank you all for joining what is our first webinar in 2021, the first Outcomes4Me webinar in 2021. Today, we are delighted to welcome back Director of Clinical Trials and Breast Oncologist, Dr. Sara Tolaney from Dana-Farber Cancer Institute. Dr. Tolaney is joining us to discuss what to expect in 2021 for breast cancer patients. We were just saying there's been a lot of data recently, a lot of exciting actually news, so looking forward to discuss this together. We will cover in particular updates from the San Antonio Breast Cancer Symposium, expected new trends in clinical trials, and also the long-term impact of COVID is having on the breast cancer community, as well as a number of questions we've received on prognosis for certain types of breast cancer patients. For those of you that don't know me, my name is Maya Saeed. I'm the co-founder and CEO of Outcomes4Me. Our goal is to help empower breast cancer patients with tools and resources to better navigate care. Through our mobile app, patients can have access to free resources and information, including clinical trials, to help them manage their disease. The format of today's discussion will be part discussion and part Q&A. We did receive a number of questions ahead of this that we'll go through, but also I would encourage everybody that's live with us today to send questions via the Zoom question box, and we will do our best to get answered them as we go through the discussion. But let's get started. And again, delighted to have you here, Dr. Tolaney. And please, give us a brief introduction about yourself, and then we'll jump right into answering some of the questions we've received and we're receiving.
Oh, thanks so much, Ryan. Thanks for having me. I'm a breast medical oncologist at Dana-Farber Cancer Institute and have an interest in novel drug development in breast cancer. And it's a really exciting time to be in this area, given all the new therapies that really have been coming along. A pleasure to be here.
Great, thank you very much. So let's kick this off. So with some of the exciting upcoming trials for breast cancer patients. So how does someone, what's out there? How does someone sign up for them?
So there are a lot of really exciting drugs that have come along, which is wonderful and really nice to see. And so I think, some agents, for example, that have been really making a large impact on practice include drugs like antibody drug conjugates. These are drugs that really take an antibody targeting a particular receptor on cancer cells, but very cleverly linking that antibody to chemotherapy. And so the idea is that you're able to deliver chemotherapy in a targeted manner into the cancer cell, and really trying to spare healthy cells a lot of the side effects, but at the same time able to deliver very high concentration of chemotherapy into the cancer cells. And so these agents have really changed practice, over the last couple of years. We have the original antibody drug conjugate in breast cancer was TDM1, but we now have approval for sacituzumab govitecan, which is approved now for metastatic triple-negative breast cancer. We also have approval for trastuzumab deruxtecan, also some people call TDXD or DS8201. This is another very clever antibody drug conjugate that has demonstrated very impressive efficacy in metastatic HER2-positive disease, but in fact also has trials ongoing in what we call HER2-low-positive cancer. So even patients who may be technically HER2-negative, but have a teeny bit of HER2 expression, that antibody is still able to bind to the HER2 and deliver the chemo into the cell and seems to have robust activity. So there are lots of trials ongoing looking at antibody drug conjugates, including the ones we just mentioned, in very novel combinations, so adding additional drugs to the antibody drug conjugate. And then there are also lots of other really exciting trials. So obviously immunotherapy has finally made its presence in breast cancer, but we still need to learn more. And so there are lots of novel combinations being explored with immunotherapy, trying to see if there are ways to make it work even in PD-L1 negative cancers, for example. Trials looking at novel combinations, even in the preoperative setting, even postoperative setting. So again, lots of studies with novel agents, but I think your question also is, how do you know about them? How do you find them? How do you get involved in them? And I will say, I think the best resource in general is probably a patient's oncologist, because they know you best. They know sort of what prior treatments you've had, or what the setting is that you're particularly in, and could then help better understand what trials make sense for you. The challenge is that each center has a different clinical trial portfolio. And so I think one question I get from a lot of patients is, well, hey, I talked to my oncologist, but they can really only tell me what's going on at my cancer center. Am I missing something that maybe someone else has that they just don't have? And I will say this is where it has been a little tricky. And I know you all have made a large effort in trying to improve this, because sort of the central database, if you will, for clinical trials in the US is the ct.gov site. And I will say, even as an oncologist, I find that hard to navigate. You can put in sort of some criteria and you get a large output of trials. And but when I'm looking for a specific trial for my patient, I realize that a lot of those trials my patients aren't eligible for. And so I can't imagine as a patient trying to sift through that amount of data, because it's just almost unintelligible. It would take hours of time. And in the end, only a few trials may be what, really makes sense for someone. And so, I know, again, your site and your app has the ability to search for trials and even put in your location to help figure out, relative to where you are, what trials would make sense. And I think things like that are really helpful because it is hard to navigate this. And I think, again, really there are lots of efforts, that are trying to be done to help with this process. But, I think, again, apps that like things that you have are really helpful when someone's trying to look just beyond where they may be getting treated.
Yeah, no, thank you very much. And it's actually very exciting what you're saying on the trials and what's out there. One thing I should mention is we continue to invest a lot in our clinical trial matching and kind of precisions, including, working also with the various oncologists to find ways to better not only have people on the app find about trials, but also connect them directly to the centers to be able to kind of get access to those trials. So while we're on this clinical trial topic, obviously speaking about COVID-19 and the current climate, has that impacted the ability of people to get on trials and, just how quickly trials are going, or are trials pausing?
I will say we've learned a lot through the pandemic, and, really when we were sort of at the early time frame in March and April of last year, COVID did have an impact on clinical trials. I think we were all learning how to deal with COVID and, trying to keep our staff safe and patients safe. And it was a challenge. We had to, in fact, even at Dana-Farber, we had to pause biospecimen collection. We just didn't have enough staff on site that could be on site safely to be able to collect, tissue or blood from clinical trials. And that led to some trials just not being feasible, because some trials, their endpoint could be a change in a biomarker. And so if you can't collect the specimen to look for that, then you can't really be running that trial. And so some trials did get paused and put on hold because of, sort of limitations on our abilities to conduct the trials with staffing. And that was hard. I will say when I saw, we actually published our findings on the impact of COVID-19 on clinical trial sort of processes, because I think we learned a lot. We did see clinical trial accrual go down during March, April, and even May, but then in the summer saw things start to rebound again back to where they had been even pre-pandemic. And that's kind of where we are now, is we are sort of at accrual rates that are very similar to where we were before the pandemic. And I think it shows you that we've learned to make accommodations to make things work smoother. And in fact, I think we've learned some lessons that I hope will stay. So for example, we've worked with drug companies to ship patients oral investigational agents where we weren't able to do that before. And now, we can do sometimes a telehealth visit, have patients get local labs and ship them the drug rather than making them come on site, have labs and, pick up the drug on site. And that's made a huge difference in the ability for patients to to be able to stay on studies, particularly patients who were traveling from a distance, which isn't so easy these days, to come to our site, for example, to participate. So I think that's been one lesson we've learned. We've learned how to have staff rotating on site. We have to keep our staff also socially distanced. And we've learned how to make it work to be able to do what we need to do with keeping, the right numbers of people on site to make things happen. So, I think, again, a lot of important lessons have been learned. And I think now I would say, at least at our center, we've taken these lessons to heart and have been able to keep trials running really at a very similar pace to how they were prior to the pandemic. And again, are trying to keep in place a lot of the good processes that have come out, including doing a lot of stuff electronically that used to be done by paper. So, some improvements I think are going to come out of this.
Yeah, no, that's fantastic. I mean, actually, I didn't realize that. So that means that for some trials, people may be able to have the entire trial run more or less remotely. Is that right?
Not the entire trial, no. I mean, we do, for safety purposes, obviously, we do need to see patients. We do need to examine people. Some trials run with, our infusional therapy. So it's, I will say there's not a complete trial that I have right now, which is all remote, with the exception of maybe one study, which is a clever trial, which is actually looking at home administration of a sub-Q Herceptin pertuzumab, which is pretty clever. And that actually does allow all telehealth and sends a nurse to the patient's house to administer the drug. Really pretty perfect during the pandemic, for patients not to be having to come in. But, most trials are not like that. And so patients still do need to come in, but there are some exceptions that are being granted by, the sponsors of the trial to allow for some visits to be done via telehealth. And, that was never used to be allowed. And we do allow in some trials to have some local labs instead of making them be done on site, which has been tremendous for patients. And I think it goes to show you that you can do this safely, periodically, and, should really be something we take to heart and incorporate moving forward.
That's great, because I would think this could help a lot of people that may not be able to be on trials, now allow them to get on trials.
I mean, I completely agree. Just think of all the time that is spent in travel for many patients who aren't near a trial site, how difficult that is, how expensive that is, how much time away from their family that is. And so I really think we need to continue to make these accommodations.
Great. I do want to stay on the topic of COVID-19 for a couple related questions. So first is, have you seen, has it impacted negatively breast cancer patients? In particular, we know, and we've had the conversation with you in the early times of the pandemic, where chemotherapy was being postponed, where also screening, I think a lot of doctors came out saying kind of, don't postpone screening, and hence, the rate of diagnosis. Any perspective in terms of how has that impacted the treatment of breast cancer, but also the detection of breast cancer?
Unfortunately, there has been a lot of delays in screening. I think, lots of sites during March and April in particular stopped doing routine screening. And that's, came all back at most places, come May and June of last year. But I think many patients also, were delaying screening, trying to avoid coming in, to hospitals for that. But we have seen, unfortunately, a rise in the stage of cancers that we are detecting. So we have a lot more patients who presented with palpable breast abnormalities or nodal involvement. And so it does make us sort of suggest that maybe these delays in screening are sort of increasing stage at time of presentation. So, it really does highlight the need for us to continue to enforce the importance of screening. I will say our center has put into a lot of safety measures to keep patients distant, socially distanced from each other, minimize the number of people on site. They created longer hours, so that there'll be fewer patients on site, fewer patients in waiting rooms. In our case, sometimes it does mean we used to always give mammogram results right at the time of the mammogram, but now we're not always doing that, again, really to keep patients turned over and not sitting around in the clinic to really prevent exposure. So and everyone's masked. So I think there have been great measures put into place to keep screening going. And I would really encourage people to not delay screenings, because I do think, unfortunately, we are seeing an uptick in stage at presentation, really reinforcing the importance of routine screening. So, you know, again, I think important lessons learned, and I think we've all learned how to keep, you know, cancer centers, for example, safer to allow for things to proceed.
Okay, great. Well, let's talk about hopefully the end of this pandemic. So the vaccine, last question that's directly related to COVID-19, which is on the vaccine itself. So two questions. One is the vaccine safe in general for breast cancer patients, and whether they're on active treatment or not. We get this question all the time. Can you take it, and at what time to take it? And then we had a specific question that actually got submitted that I'm going to read, that's also linked to the vaccine. That way we can cover all of them, which is, does the Pfizer vaccine require you to get the injection in both arms? I have noticed someone that had lymph nodes reaction, and they are cautioning people with lymphedema risk.
Yeah, that's an interesting question. So, you know, I think one challenge is that we don't have really robust data for efficacy, if you will, of COVID vaccination in cancer patients. You know, the patients on active therapy were not included in, for example, the large randomized Pfizer and Moderna trials to have, you know, clear data to suggest antibody response is the same in someone on, for example, active therapy. However, there's no reason to think that there's any safety concern in someone on active treatment. Certainly we give a flu shot, for example, to patients on active therapy and don't have any concerns. I will say our center is very interested in studying this. So we actually have written a protocol to look at not only efficacy, but also safety in patients either who've been on distant treatment or on active treatment. And so this is something that we are studying, you know, really looking at blood draws in patients pre-post vaccination. So certainly if you are interested in contributing, don't hesitate to ask if you're getting your vaccination, because I think we can learn a lot from it. But I'm not concerned about the safety. Again, we don't really have great efficacy data, but I have every reason to believe it'll be just as effective. So we are telling and counseling all our patients to get vaccinated. In terms of your second question, though, about lymphedema, that's a really interesting question. And I will say it actually is just something that has been coming up, because we are noticing many patients get adenopathy after vaccination. Even some of my colleagues at work have been noticing, you know, enlarged lymph nodes after their vaccine, particularly after the second vaccine. And so this actually came up in our breast imaging clinic the other day. Is we've had a number of cases of patients come in for screening after being vaccinated, where we thought they had, you know, lymph nodes due to potential cancer recurrence. And in fact, it was on the same side where they were vaccinated, just timing wise was right after their second vaccine. So we are actually now changing all our screening questionnaires for people coming in for routine breast imaging to say, you know, did you get the COVID vaccine and when was it last administered, and trying not to do the screening immediately post second vaccination, because we are seeing this increased rate of adenopathy, which, you know, good, they're revving up their immune response. But, you know, I think, again, can be confusing in the setting of imaging and can cause a lot of anxiety, certainly, to think that there could be an abnormality. So it isn't unusual to see the adenopathy, particularly after second vaccination. And, you know, I would say in someone who's had a prior axillary dissection, you probably do want to get your vaccine on the contralateral side. So not pick the arm that had the big axillary dissection, rather use the other arm. And it is okay to get both vaccines. I got mine in the same arm. So it's okay to get it in the same.
Okay, great. That's very helpful. We're getting a number of questions also from the live audience. Let me go through some questions. And also, you know, you highlighted some of the San Antonio, you know, kind of latest development, but I do want to cover a few questions. One of them is, are there essentially the current advancements for patients with triple negative breast cancer that has metastasized? So that's a question that we got. What's the latest advancements for that patient population?
So, you know, I think we've made a lot of headway for metastatic triple negative disease over the last couple of years, which is really nice to see. I think traditionally we had thought the standard was really chemotherapy, but now we actually have several other options. So if someone has a PD-L1 positive metastatic triple negative cancer, we do now offer chemotherapy with immunotherapy, and where there has been proven to be added benefit by adding the checkpoint inhibitor, so either atezolizumab or pembrolizumab, to chemotherapy. So that is one, I think, really nice advancement. Another is the approval of sacituzumab govitecan, which is the antibody drug conjugate we were alluding to, which had been compared to standard chemotherapy in pre-treated metastatic triple negative disease and was found to be dramatically better than standard chemo in terms of, really keeping disease controlled and actually allowing women to live longer. And so that drug is now being studied in other combinations and in earlier lines of therapy. So I think we'll see a lot more from that drug in different ways in triple negative breast cancer. We've also seen introduction of Parp inhibitors for triple negative disease that has a BRCA mutation, or now even PALB2 mutation. So there do seem to be, targeted drugs that now again have approval. And there are lots of other drugs that are being studied in this space, including other novel antibody drug conjugates, such as, the one by Seattle Genetics that's targeting LIV1A. Daiichi also has a really very interesting antibody drug conjugate called DS1062. So there are lots of very exciting new therapies that are moving in triple negative disease.
Okay, thank you. So now moving more to the hormone positive disease. So we have a number of questions linked to that. So the first one is, if palbociclib fails, can you receive another CDK4/6 inhibitor, example, ribociclib?
Really good question, and we don't have the answer to that question. So the idea is if you get a CDK4/6 inhibitor with an endocrine agent and it stops working, should you just, maybe one could think, would you just switch the endocrine therapy and give a different CDK4/6 inhibitor, and would you see activity? And we don't know the answer to this question. And in fact, there are several trials that are ongoing actually looking up to answer this question that haven't been reported yet. One is the PACE trial, which is looking at using palbociclib in someone who's previously had a CDK4/6 inhibitor. And the other is the MAINTAIN trial, which is looking at ribociclib in patients who've had a prior CDK4/6 inhibitor. And we had a prior study that had looked at abemaciclib in this case as well. And so, I will say, important question, but we don't actually have the answer. I will say I'm not standardly doing it outside of clinical trials. I think it's an important question to address. In truth, I do wonder if the answer is going to be a little bit dependent on the individual patient and why they developed that resistance, because sometimes patients develop resistance not to the CDK4/6 inhibitor, but rather to the endocrine treatment they were on, in which case then maybe it would make sense to continue the CDK4/6 inhibitor and just switch the endocrine treatment. But sometimes it's true resistance to CDK4/6 inhibition, and maybe you need another drug to sort of reverse that resistance. And so, that's where I think things like genomic testing may actually better help us understand which patients may benefit from continuation versus not. But I think this is really an unanswered space at this time.
So you said you don't understand the basis switch, add the other one. This actually we got, as people know that use our app, people can ask questions directly on the app. And so actually one question we got this morning was of a patient that was asking, if you fail the CDK4/6, other trial, what do you do next?
Yeah, so it's a really important question. So certainly one would be to do a trial looking at continuation of CDK4/6 inhibitor, because we don't know the answer to that. But there are actually, the standard approach after getting an endocrine agent and CDK4/6 inhibitor is usually to go on to a different endocrine therapy, either by itself. So for example, if you got an aromatase inhibitor and a CDK4/6 inhibitor and it stopped working, oftentimes we go to fulvestrant, so different hormone treatment. Sometimes I will give that with another drug. So if someone has a PI3 kinase mutation in their tumor, which is about 40% of hormone receptor positive patients, then I would give the fulvestrant with a drug called alpelisib, which is a PI3 kinase inhibitor. Whereas if they don't have a PI3 kinase mutation, either I would give the fulvestrant alone, or I would give it with another drug called everolimus, also known as Afinitor, which is an mTOR inhibitor. So, I think I am utilizing genomic testing to understand if someone is a candidate for alpelisib or not after progression on their CDK4/6 inhibitor, and then making that decision.
Great. We did get a live question on the app. So the question is, are there any immunotherapy trials for hormone-positive breast cancer? So the question does not specify metastatic or non-metastatic.
So excellent question. We could address it for both settings. So in the metastatic setting, there are trials ongoing. I think initially there was some concern about using immunotherapy in hormone receptor positive disease, which, just in general, hormone receptor positive cancers don't appear to be quite as immunogenic as a triple negative tumor, meaning if you look at them under the microscope, hormone receptor positive cancers don't tend to have a lot of immune cells in them. They just tend to be what we call less immune rich. So they call them colder tumors because they just don't have all the immune cells there. So most of the work, honestly, at the initial time point focused on triple negative disease, just because it seemed like immunotherapy may have greater efficacy in that particular, subtype of breast cancer. But there is definitely interest in looking at it in hormone receptor positive disease. In fact, our group has previously done a trial in hormone receptor positive disease where we tried adding immunotherapy to chemo, and in fact, it didn't add benefit. But I think we learned some lessons from that study, and so now we're doing a trial which is specifically for hormone receptor positive metastatic breast cancer if your tumor is PD-L1 positive. So the trial will test your tumor for PD-L1, and if it's positive, then you get either sacituzumab govitecan, so that antibody drug conjugate we were talking about by itself, or you get the sacituzumab with pembrolizumab. Really looking to see if we can add immunotherapy to an antibody drug conjugate in someone who has a PD-L1 positive cancer that's hormone receptor positive and make it work better. We also have trials looking at hormone receptor positive patients that have a high tumor mutational burden, which is probably somewhere between 5 to 10% of all breast cancers. It's not that common, but if your cancer had genomic testing and has a tumor mutational burden, in this case over 9, the trial looks at a combination of ipilimumab and nivolumab, so 2 different immune therapies given together. And so those are for the metastatic setting. In the early disease setting, there are also trials ongoing looking at immunotherapy. There's 2 large registration trials trying to add immunotherapy to chemotherapy in patients getting chemo prior to breast surgery. One is looking at pembrolizumab, another looking at nivolumab. And there's also a trial looking at adding CDK4/6 inhibitors with immunotherapy to endocrine therapy in patients with hormone receptor positive disease prior to surgery. So definitely lots of studies ongoing in this space.
Great, thank you. We had a couple of questions for hormone positive but PR negative breast cancer, so ER positive, PR negative, and I'll read both because they're related questions. So the first question is, I hear that PR negative has worse outcomes than PR positive because progesterone counteracts estrogen. I'm not sure I have that right. Is that correct? Would adding progesterone have a protective effect for PR negative women? And then more broadly, the other question, so that we can just address questions on that group, was, are there any new treatments that are specific for ER positive, PR negative breast cancer, as PR negative is currently treated the same way as ER positive, PR positive in my experience?
So it is true that in general, we do approach ER positive, PR negative tumors as the same as we approach ER positive, PR positive tumors. So we do treat them all like hormone receptor positive cancers. And the reason being is that, these cancers are still dependent on ER signaling. It is true that if someone has PR negativity, it is sort of an indicator of a little bit of a worse prognosis relative to a PR positive cancer. So maybe it's doesn't do quite as well with endocrine therapy as someone who's both ER positive and PR positive. But again, the approach is the same. And in fact, a lot of our treatments have been found to work similarly, regardless of the PR status. So at this point in time, we do not change our treatment approach based on the PR status alone. It is really dependent on, ER status.
And trials, are there anything?
Sorry, yeah, no, good question. We do not have any trials that I'm aware of that are specifically addressing, PR negative, ER positive patients.
Okay. So another question we got, for people with triple positive breast cancer and low expression of HER2, early stage 1, early stage 1-2, is cytotaxan, taxotere, Herceptin the appropriate regimen? And actually, at some point I'll get to, this whole question around how much of a positivity you are on those different receptors and how that impacts treatment.
Yeah, particularly now with HER2, this is becoming a big question because it turns out that it may be important to understand how HER2 positive you are. This particular question seemed to suggest that the patient was technically HER2 positive, and because they had a triple positive tumor, so ER positive, PR positive, and HER2 positive, but maybe the level of HER2 expression, wasn't super high. It maybe just barely met positivity. We always want to be able to treat HER2 positive cancers with HER2 directed therapy in the event that they will benefit from it, because the benefit of HER2 directed therapy is just so great. And so, it is true that if someone has HER2 positivity, I will generally add, Herceptin, for example, to their chemotherapy. The regimen that was mentioned, the taxotere, Cytoxan, trastuzumab regimen, has been studied in HER2 positive disease. It was studied predominantly in early stage HER2 positive disease. There was a single arm study that had been done of that specific TCH regimen, taxotere, Cytoxan, Herceptin, in stage 1 and 2 patients, and patients had excellent outcomes. And so, it would be a reasonable thing to consider. I will say our group often will even do Taxol by itself with Herceptin in stage 1 cancers. So I think it would be a more nuanced discussion to better understand the exact situation of that particular tumor. But in general, I think the answer is that if there's HER2 positivity, we do generally want to add HER2 directed therapy. But we are learning that even in someone who has HER2 negative breast cancer, if there's low HER2 positivity, there may be benefits for drugs like antibody drug conjugates like trastuzumab deruxtecan, and that is being studied in the metastatic setting for these HER2 low cancers.
So maybe, and this we got a few other HER2 low, but now on the triple negative side. So and I'll go through them. So some people who are considered triple negative can also be HER2 low with local disease. For neoadjuvant treatment, would you consider triple negative regimen or HER2 low? So I guess based on what you said, you would.
We're not quite there yet. So,
okay.
This is all something we're studying. So there was a large randomized trial that actually just recently finished accruing, comparing trastuzumab deruxtecan, which is that antibody drug conjugate against HER2, and comparing it to standard chemotherapy in metastatic HER2 low positive cancers. They were predominantly hormone receptor positive, but did include a cohort of triple negative cancers. And we're waiting on that data. So we don't know that specifically using trastuzumab deruxtecan will be better than standard chemo. There's some suggestion that could be the case from their early data, but we don't know that yet. And so it is in someone who presents, for example, with an early stage cancer where you're giving preoperative treatment outside of a clinical trial, we would not do anything differently. If you were HER2 low, the standard would still be preoperative, chemotherapy-based treatment.
Okay. Actually, we got the question both on the chat, and we got a similar question as submitted. Is there anything on the horizon that could look like a cure? A personalized immunotherapy, vaccines?
Obviously this is our biggest goal, is to be able to cure metastatic breast cancer. And, I think the biggest thing that drove some excitement has been immunotherapy as a potential cure, with the idea being that if you can rev up your own body's immune system to see your cancer as foreign, then it should always be able to monitor that foreign thing and keep it, killed and controlled. I will say there are a couple patients that we have encountered that have had sort of their cancer melt away with immunotherapy. In fact, there's one particular patient in our practice who's now been off therapy for a few years now after immunotherapy and hasn't had her cancer come back after having known metastatic disease. Could she be cured? Possibly. And I also have another patient with a BRCA-related cancer that went on to a trial of a novel treatment that now is a couple years out from her last dose and also doesn't seem to yet have a recurrence. So we're learning, but these I think are really rare situations and one we get really excited about and very nice to see, but I think unfortunately it's not the standard. And so I think we still have a long ways to go to really cure breast cancer, but we're learning and we are hopefully moving in that direction.
Great, thank you. So now moving to lobular breast cancer. So a couple of questions there. One is any best practices guidelines for follow-up surveillance of lobular breast cancer recurrence, given that it's difficult to image and currently follow-up is triggered by symptom reporting only. Is there a better way to find spread recurrence earlier? And then another person saying just they're interested to know about any new research regarding lobular breast cancer.
Yeah, so I think it is a big area of interest because, the biology of lobular breast cancers is different than ductal carcinomas, and yet we do treat them, generally speaking, the same. And so, we are learning that there are differences in response to some drugs based on their histology of being lobular versus ductal. So we are actually trying to specifically run some trials trying to assess differences in outcomes for lobular patients. So for example, one of my colleagues, Otto Metzger, has a large interest in lobular breast cancer and specifically was looking at impact of endocrine therapy and CDK4/6 inhibition in lobular cancers compared to ductals, and so has that trial just completed. But I think, again, at this time, we generally are approaching them with fairly similar treatment approaches, but hoping to learn more. It is true that the imaging for lobular cancers can be very tricky. Even in terms of screening for breast cancer, sometimes lobular breast cancers can be missed by typical screening modalities just because of the way they percolate through the breast rather than forming like an initial mass. Sometimes they're just sort of infiltrating, and so it's a little harder to detect. And it does continue to be a struggle, and not only in terms of screening, but then also in patients who have metastatic disease. Sometimes those cells track along lining, so they'll track along the peritoneal lining or track along the gut lining, and it's hard to image and hard to assess response. And so there are lots of things that are being looked at, including PET imaging and so forth. But, I very much agree that it is an area that we need to do better with.
Great. A question on DCIS. So based on the newer research, is endocrine treatment after lumpectomy always recommended for hormone positive DCIS?
So good question. And I will say it is a little bit dependent, how much DCIS was there, what grade of the DCIS was it, and does the patient have other contraindications to endocrine therapy? For the most part, the general answer is yes, usually we are recommending endocrine therapy for the majority of our DCIS patients. But again, there are some circumstances where maybe someone has just a tiny bit or someone's older and has a contraindication to endocrine therapy, and we don't, utilize it in that situation. We also don't utilize it if someone's had a mastectomy. And so it's usually indicated in someone who's had a lumpectomy with ER-positive DCIS.
Great. Now talking about some of the side effects. So first on Arctic cold caps, how effective are they in preventing chemotherapy-induced hair loss?
So I will say that cold caps or utilizing scalp cooling has been a tremendous benefit to our patients. And something I think it is important to always discuss with your oncologist if you're interested, and if you're starting chemotherapy, because with certain chemotherapies, scalp cooling works really well. With other chemotherapy, not so well. And so knowing that upfront is important to help you decide whether or not you want to do it or not. Generally speaking, it doesn't work as well for AC chemotherapy, so adriamycin and Cytoxan. The rates of hair preservation are substantially lower than if you were getting a non-anthracycline-based chemo. So if you got something like Taxotere and Cytoxan, it works really well. Or if you're getting Taxol by itself, it works really well. And so, I will say it is important to discuss it, and whether or not, you have metastatic therapy, getting metastatic treatment with, weekly chemo, or getting early disease treatment, with TC. I definitely think it's worth a discussion. I will say one area that I continue to struggle with is, unfortunately, insurance is not uniformly covering scalp cooling, which, I think is a problem. And is, something we do discuss with patients up front, that unfortunately, you could end up paying out of pocket for it, which is hard for many patients.
Okay. Now, speaking of just fatigue as a symptom, what recommendation do you have for patients who experience persistent fatigue after chemotherapy or radiation in spite of gentle exercise, more balanced schedules, and other recommended management strategies? That's a difficult one. Yeah.
Very tough one. I mean, I will say it is a problem.
Yeah.
I tell patients, particularly after they've had chemotherapy and radiation, for treatment of early disease, that you don't kind of feel back to yourself sometimes for up to a year, after therapy is complete. It's not, I think we all think, okay, the treatment's done, I should be getting back to myself. And, people really feel that they're not really 100% back to how they were before these treatments for quite a while. And so I will say, be patient, because, unfortunately it does take time. But I think all those strategies that were mentioned are excellent, that, there is a lot of data that exercise does help with recovery, and, can make people, do better in terms of their fatigue.
Right. Just on the comment on the cold cap, we just got a question through the chat. Any risk of metastasis to the scalp when using cold cap?
So it's a good question, because one would think that when you're cooling the head, that you're not getting chemo penetration to the scalp, and that there would be higher risk of scalp metastases. And in fact, that was my concern when scalp cooling first came into play. But in fact, we have seen no increased rate of scalp metastases or brain metastases despite using scalp cooling. So it seems very safe to use.
That's great. So actually, within stage 4 breast cancer, one of the questions we had is how many, if any, breaks in chemotherapy can patients with stage 4 breast cancer take?
So that's a good question, and one I don't really have a great answer for. I think it's hard to go through chemo after chemo after chemo without a break. And so, I think it really is a very sort of patient-dependent discussion with your oncologist about when a break may be appropriate, how long of a break feels safe. And, I think, again, it's so dependent on the volume of cancer that's present, how you're responding to the current treatment regimen. And so it's a hard question to answer. I don't think there's a concrete number that I could give.
Okay. Actually, we had a number of questions linked to genomic testing when you covered that. So one of the questions is on the chat, should I wait for progression before doing genomic testing?
So also a good question. And generally speaking, yes, the optimal timing to get genomic testing is usually at a time of progression, particularly if you're getting a ctDNA assay to assess genomics, that you're going to have the highest yield of ctDNA and when there is tumor growth. Sometimes you may not get anything if you draw blood and you're having a great response to treatment. It just may not pick up enough to do the assay. And so we do usually try to assess genomics at time of change, because it's also when you may expect to see changes in gene mutations. So yes, I would agree, either a biopsy at time of progression or getting a ctDNA assay at time of progression.
Okay, so that then answers another question that we had on the chat, but I just want to make sure I stated which is if genomic testing was not undertaken at diagnosis or ER positive de novo, is it worth doing before a change of treatment upon progression?
Yeah, I
Yes,
would.
yes, yes.
So
Yeah.
I think particularly in ER positive disease, we're now knowing if you have a PI3 kinase mutation could impact, treatment recommendations. I do recommend all patients have genomic testing.
We had a couple questions. So I'm going through a couple chat questions, then I'll go back to a couple questions that were submitted and we'll wrap up. So if someone is young, only has a few bone mets, but had osteopenia, should they be on bone medications such as Zomera or Xgeva? And
So,
it may be linked, I don't know if it's linked, but I'm going to mention it because it mentions also Zomera. I've seen other studies related to using Zomera with AIs to boost preventing metastasis. Have there been any more recent studies or development from following patients in the original studies?
great question. Generally, we are using these bone modifying agents in sort of two main areas. One is in someone with metastatic disease who has cancer in the bones, where we're using these drugs to really prevent sort of complications from the bone metastases, so prevent fracture, for example. And so, that is one reason we would give either Zometa or denosumab. In the early disease setting, I think as that second question was alluding to, there is now data, particularly more robust data in patients that were postmenopausal on aromatase inhibitors, predominantly with stage 2-3 disease, that adding Zometa can help prevent recurrence. I will say when these data came out, I was a little skeptical. I thought, why is a bone modifying drug that I use to treat osteoporosis and keep bones strong and prevent fracture, why is it preventing breast cancer from coming back? Is this real or is this like a fluke? And so at first I wasn't so, I didn't buy into it completely at first, but now we've actually seen several trials and actually have a very large meta-analysis confirming that using Zometa in this setting can help prevent recurrences. And so really has become something that we've standardly incorporated in discussing with our patients, particularly again, stage 2-3 patients who are on aromatase inhibitors and postmenopausal. And so, yes, there is now, I think the best data really comes from the meta-analysis that has combined all these trials together, suggesting improvements in outcomes.
Great, thank you. Also, we got a few questions on the HER2 low. So one of the questions, if someone is 2+ on IHC, but was told they are HER2 negative, is that person HER2 low?
Yes, so the way HER2 low is defined is if you are technically HER2 negative, meaning you are not IHC 3+ or FISH amplified, but you have 1+ or 2+ expression. So having an IHC of 1+ and 2+, but not being FISH amplified would mean that we call you HER2 low. This is a new thing. It's not, again, something that used to exist, but now we think about. So the answer to that is yes. It's probably about 60% of all breast cancer that is actually HER2 low. It's about half of ER positive disease and probably a third of triple negative disease that has HER2 low expression.
Okay. Also, one of the questions we got submitted ahead of time was around, the type of treatment, in particular at an older age. So I'm going to read the question. I have tumor, 0.8 centimeters, stage 1, growth grade rate 2, both hormone positive, HER2 positive, age 81. What treatment do you recommend? Lumpectomy with or without radiation, mastectomy with or without radiation, and both oral? So I guess that's a question that comes up quite a bit around, if you're 80 or older, is the treatment considerations different, and how do you think about that?
It is an important question and a challenge. And the reason is that, as we get older, obviously we can tolerate therapy differently and have different rates of toxicity. And so when we're weighing risks and benefits, that certainly comes into play, is how will toxicity play out in this older patient. But on the flip side, we also know that this patient's longevity is different, right? So in my mind, it's not so much the numerical age that matters. It's more what's this patient's performance status? What are their comorbidities? How long do we think this patient would live otherwise? If they didn't have breast cancer, given their other medical issues, is this someone who's going to live 10 plus years? Or is this someone who's frail and has multiple other medical problems where we're concerned that they may not be able to live several years because they are older? And those are two totally different scenarios where I'm going to make very different treatment recommendations, because if someone's going to live more than 10 years, my worry is that HER2 positive cancer can come back in the first 3 to 5 years. So could it really impact that patient? Whereas if someone's not likely to live more than 2 or 3 years, then, giving them therapy that potentially has toxicity doesn't seem worth it. And so to me, the biggest first assessment is really, what do we expect that patient's life expectancy to be otherwise, and how are their other medical problems? And I use that to weigh in, what makes sense in that scenario. Again, it's not the numerical age that matters. It's really, how their health is otherwise. And then, for this particular patient, I think the question was really specifically for stage 1 HER2 positive cancer, where risk of recurrence is going to be a little lower than in others. And in fact, is a large area of interest in our group, where, trying to, what we call de-escalate therapy, try to give a sort of more tolerable chemo regimen to that HER2 positive patient is a big interest. In fact, our group has done some work trying to look at TDM1 in this setting with some success, showing very good efficacy. And in fact, one of my colleagues also did a study in older women looking at TDM1 with HER2 positive cancers. And that study just completed, so we don't have those data yet, but definitely would be a discussion we'd have to have with an individual patient information to know what the right recommendation would be.
That makes sense. Maybe a couple more questions, and then we'll wrap up. I know we keep on getting questions, so I'm going to try to cover as many as I can in the last 5 minutes. So one of the questions was, for triple negative, studies have compared neoadjuvant to adjuvant treatment, and studies may suggest better outcomes for adjuvants. For patients with no lymph node involvement, would you do surgery first?
So that's actually a really important question. And the question is really, does order of treatment matter? And it used to be, I would have said no, that there were really old studies that compared giving chemo before surgery to after surgery. And in fact, there was no difference in long-term outcomes towards the patients. There was an advantage if you got the chemo up front to being able to have higher rates of breast conservation, meaning, it sort of made sense. If you gave the chemo first, you could shrink the tumor down. And so maybe you'd have more patients who are able to keep their breast because they need less surgery because the tumor was smaller. And so that was an advantage. So if someone had a big tumor who's otherwise going to need a mastectomy but wanted to keep their breast, we used to say, okay, let's give the chemo up front, shrink it down, and let them keep their breast. But I think we've also learned it's not just about trying to shrink the cancer down to make for a smaller surgery, but in fact, getting the chemo up front actually gives us a lot of information, because it teaches us how sensitive was that cancer to that chemo. Because if all the cancer disappears from the chemotherapy that we gave, well, we know that worked really well, right? Because even if there had been microscopic cells floating around in the bloodstream, it probably killed them too, if it killed everything in the breast. And so that turns out to be a really good prognostic indicator that if you achieve what we call a pathologic complete response from getting your chemo first and you find nothing at surgery, then rates of recurrence are substantially lower than if there's cancer remaining at the time of surgery. But I think importantly, we've learned that even if cancer is remaining at the time of surgery, we now know we can do something to help improve patients' outcomes, which is give them a different chemo after surgery. In this case specifically, Xeloda has been studied in patients with residual disease and has improved, actually overall survival from giving that. And so in my mind, if someone has a tumor that's, usually over 2 centimeters or has lymph node involvement that's triple negative, I want to give them chemo first, because I want to understand how that chemo worked in that patient to help me know if after surgery I need to give them extra therapy or not, because that will actually have large implications on outcome. And so really it should, in my mind, be standard of care to give preoperative therapy to most patients with stage 2 and 3 disease. For stage 1, we're okay taking people to upfront surgery.
And for stage 1, just so I understand it, I mean, you said we're okay to take them to upfront surgery. What would be the better option?
The reason I say that is because when someone has a stage 1 cancer, I'm not really always sure how much cancer there is. Is it teeny tiny, or is it enough where it's a little bigger of the stage 1, there's a range, and that would impact sort of how much chemo I would give. And so understanding what was found at the time of surgery helps me know how much treatment I want to give them afterwards, because I don't want to over treat them by giving sort of the kitchen sink to them. What if they ended up having a super tiny cancer? Then I've given them too much treatment. So the stage 1s, I like to know what's found at the time of surgery to help guide what to give them afterwards. But stage 2 and 3, I know I should give them a certain chemo regimen up front. But what I want to know is how well did that work? And that's why I want to give it up front, so I can tailor the adjuvant portion of the treatment after surgery.
That makes sense. Just a couple more questions and I'll wrap up. Are there any new imaging techniques that can help to track the efficacy of the treatment so that the treatment can be changed in case it doesn't work? So in other words, that could spot, maybe progression, or even actually the fact that the tumor is not shrinking. Yeah.
I mean, I think it's a key question, because it's really saying, can we have early predictors of response and resistance? Can we know before we have to wait through all this treatment to get your scan to know if it's working? Can't we know this earlier? Isn't there a test you could do quickly within the first couple doses of treatment to know if it's going to work? And currently the answer to the question is no, we're not there yet. But there are lots of things being done to study this, because it is such a critical question. One question is, could you just do a blood test? Could you do like a ctDNA assay and assess if there's early response or not? And would that predict who's going to end up benefiting? And so not waste someone's time on a treatment that's not going to work for them and give them more side effects. Could we know that early on with a blood test? And so that is actually being studied, is looking at things like a ctDNA assay as an early predictor of response or resistance. But then also a good question is also, is there some fancy scan you could do to see if there's an early predictor of benefit? And there are lots of things that are getting studied depending on what the drug is, but there are lots of sort of radioisotopes that are being studied with sort of fancy PET scans, if you will, to see if we can predict early with early imaging. But these are all in development and all in clinical trials right now. So important question, but not a sort of good answer yet, but lots of things that are being looked at.
Okay. So one of the questions we got on the chat, and that probably is the last one I'll pose on the chat. Thank you all for sending all these questions. Hopefully we can follow up after the webinar. The question is, and actually I relate to this because in the last probably 4 weeks, I know 5 people close to me that were diagnosed with breast cancer. None of them had the genetic inherited, so they did genetic testing. So the question is, what are your thoughts on a woman with no genetic abnormalities and no family history having breast cancer twice? What do you think my statistics are for the 3rd recurrence? First was 100% DCIS, had bilateral mastectomy. Second was triple positive IDC with DCIS, local recurrence only. And so that, and I guess, yeah, this notion of recurrence and in the absence of inherited gene.
I think there are a couple of questions, because in this particular scenario, it may be a true recurrence, so it may not be a new primary cancer from what I was hearing, in which case, it was maybe that there was some invasive cells potentially that could have been there at the beginning that maybe weren't seen, but managed to cause a recurrence, which is different than if someone, let's say, has a breast cancer in their right breast, but gets a totally different cancer in their left breast a few years later, where you're seeing really unrelated breast cancers in them. That's unusual, to have 2 primary breast cancers that aren't, one wasn't a recurrence of the other one, they were just found at different times and are different cancers. And that is a red flag test to do genetic testing, because it, just as you were pointing out, it makes us wonder, is there some genetic predisposition to breast cancer? Why should someone be getting 2 different breast cancers? What's the chance of that happening? And it is generally low without some predisposing risk factor. But as you point out, we don't always find the genomic risk. And so, one, it could be we just don't know what the gene is, that maybe this is an inherited form of breast cancer, but we just haven't figured out that gene. We don't know all the genes that are, cause breast cancer. Two, could it be some exposure? You know, there are patients, I mean, this is a really rare scenario, but if someone, for example, had Hodgkin's disease and had mantle radiation, that would leave them at very high risk for bilateral breast cancers in their lifetime just from the high dose radiation exposure. So there could be other, you know, predisposing risk factors. But beyond sort of the known risk factors, why is this occurring without genetic risk? You know, the answer is we're continuing to struggle with this because there are so many sort of small risk factors that we see for breast cancer. But why is it that someone gets, you know, 2 cancers versus not? You know, we don't know.
Great. Unfortunately, we're not going to be able to answer all the questions, but so I do want to wrap up. I do want to wrap up with a actually somebody that posted a non-clinical question on a positive note, which is, I'm 36 and 2 years out from stage 2 with no evidence of disease. I feel like I need to give back to honor all the work of people like you. How can I do that? Any thoughts? Or I'll give you the last comments and then I'll just wrap up and tell people how they can access the webinar. But maybe with that question and more broadly, any concluding remark, Dr. Tolaney?
Well, I mean, I was so generous for people to think about how they can give back when obviously they've gone through a lot themselves dealing with cancer. And, you know, I will say it's only because of people willing to participate in research that we're able to get new drugs for patients. And so the contributions from patients who are participating in trials is really tremendous and really a gift that you're giving to other people in future generations. So, you know, thank you to all of you who are so willing to give and participate, because we realize, you know, often trials ask a lot of patients and it's hard, and we are very thankful for all that you do because it makes such a big difference. And so definitely always ask, because there are things even in patients that are a few years out. For example, we have studies where we're looking even just at blood collection in patients who've completed their therapy, looking at ctDNA in patients who may be years out from their therapy. So there are always studies that are ongoing. And so certainly we always appreciate you asking and would love to have everyone's participation. So thank you.
Thank you. And I should say, actually, we get also a lot of questions from people that are using our app that says, how can they give back? So that's something that also we're taking at heart, and we're going to provide a platform where, you know, with the opportunities for people to connect, you know, with things where they can, you know, give back. So we're going to have to wrap up. Thank you so much for your time. I know there's still a few questions that we haven't answered. I would recommend that please submit them via the app. We'll get to them. We'll get back to you on them. So, you know, you can submit them through the feedback button of the app, and we'll make sure we address them. We're also going to be making this video available on the app. So we'll be sending an update and a message on this. And as I mentioned, this is our first webinar for 2021. We would be sending a survey what you'd like to hear about this year, so that you know, we can make sure we address all your questions. Dr. Tolaney, thank you so much for taking the time. This was very informative to me, and I'm sure to everyone on this call. Thank you so much.
Thank you so much for having me.
Thank you. Thanks. Bye.